I'm going to give an overview of the Accelerated Access Collaborative Academic Health Science Network Lipid Management and FH program. So this has evolved over the last 12 months. I don't really need to go through the data here with this audience. I'm sure most people are familiar with it. The only other comments I would add to the information displayed on this slide are that cardiovascular disease is the major driver of health inequalities in BAME communities and in socioeconomically deprived areas of our society. So I think in the current context, that's a really added impetus to improve cardiovascular disease management. The second point I would make is that the pandemic has had a significant detrimental impact on CVD prevention. We do not yet really have the data to understand the extent of that. And I'll come back to that for some of the issues we're seeking to manage later. But we can be pretty certain that the diagnosis of new patients with atrial fibrillation will have declined significantly from data we've seen in other countries, and that the management and control of hypertension will also have declined because of the impact of the pandemic and the lack of follow-up routine management of those long-term conditions, and also essentially the end of health checks during the pandemic. The other point to make is it's highly cost-effective, particularly for stroke because of long-term disability, but also because of the disability associated with heart failure, to effectively prevent cardiovascular disease. So we have, as a network of 15 academic health science networks, I think always been working on some aspect of cardiovascular disease prevention. The main area for the last few years has been atrial fibrillation, and many AHSNs started work in this space because of the new drugs available, which have increased management options, and because of new technologies available to detect atrial fibrillation. And what we're trying to do is build on that work to have an effective implementation plan for improving the management of the ABC of cardiovascular disease prevention. So these are the results from the end of the two-year national program, which ran from April 2018 to March 2020 of the AHSN network, working with many other partners and a lot of other support, Public Health England, Primary Care, the QOF system. And we aim to do two things: improve the recognition of people with AF at high risk of stroke, and second, to increase the proportional anticoagulation. And we achieved both of our targets for that, of 84% and 85%. And despite the increased cost of treating AF with anticoagulants, particularly the newer drugs, that overall resulted in significant savings to the NHS because of the reduction in stroke admissions, and because of the savings from long-term disability and health and social care costs related to that in stroke. And indeed, my life as a stroke physician has been a little less burdensome than it would have been through this effective program in improving the management of AF. So we sought to build on this, and at the end of last year, invited proposals for further national programs the AHSN network could run around cardiovascular disease. Another area of focus we sought specific proposals for was mental health, which I'm not going to talk about here, and we also considered some other programs. So, and there were basically two programs suggestions that were received. One was very narrow. It was the Dermot and the team in the Northeast who proposed an FH program. A fair amount of work, and you've heard that described by in David's earlier talk. And that was based on adult screening on the experience that Dermot and colleagues had had in the Northeast. There was also a much broader proposal put forward, which in fact I was supporting, which from Matt Kearney and other colleagues, which was to focus on blood pressure and cholesterol lowering. And after discussion, we thought it would a broad program would be challenging in terms of focus and achieving implementation. And so that was the genesis of the program that was then shaped, which was around lipid management and including FH, but not FH detection and management alone. Because clearly, if you want to have a wide population impact, you need to seek to improve cholesterol lowering in not just in people with FH. At the same time, in parallel, there was the work going on by the Associated Access Collaborative, and I'll come back to that. So again, the data on this slide, I don't need to go through about the substantial reduction in major vascular events that result with lowering of LDL cholesterol. Again, the perspective I would give is it's interesting in the stroke community, we put a lot of focus on blood pressure management and atrial fibrillation management, but cholesterol lowering has been somewhat of a Cinderella area in terms of the focus of the stroke community, even though we have very good data on the benefits of that. Now, the Associated Access Collaborative was set up to help support the more rapid uptake of new therapies coming to the market, so clearly not just cardiovascular disease. And they picked the year before this program as one of their therapies, PCSK9 inhibitors. And so AHSNs were already given a responsibility to go and increase the uptake of PCSK9 inhibitors, which they did. But the challenge, of course, is if you want to engage primary care and secondary care, but particularly primary care, in improving outcomes for people with elevated cholesterol, you don't really want to start the conversation around PCSK9 inhibitors. You need to cover the whole pathway. And the AAC team sort of started to recognize this, and with the clinical experts they then drew upon, first of all, produce some summary guidance for lipid management to make clear where PCSK9s were in the treatment pathway, and brought together with the various pieces of guidance that NICE had produced to produce this overall summary of the care pathway for the lipid management in the primary and secondary prevention of CVD. And we, as an AHSN network, would always base our programs of work along NICE guidance and pathways like this. And we particularly find it useful when there is a clear pathway that has been described for the community to work to. So we have built our program around this, and we're building on the work that was already happening in the Associated Access Collaborative. And I and colleagues spent some time speaking with colleagues in NHS England, the AAC, explaining, why our program would be synergistic and was needed to really drive the AAC ambitions. That we needed to improve the identification of patients who have elevated cholesterol, the prescribing of statins, and indeed the AAC had then included in their drug therapies for accelerated uptake high intensity statins and ezetimibe, even though the view of some, including myself, is that these are well-established generic drugs that was not really the intended purpose of the AAC, but that was because they recognize you can't drive the uptake of new therapies unless you've really got the proper steps in place for use of the established therapies. So this is a sort of then an overall framework of this joint program between the AAC and the AHSN network. When we say the AHSN network will support the implementation of something, what that means in practice is there are 15 academic health science networks, each with a population of between 2.5 to around 5.5 million. And what generally happens if there's a project is there is a manager who, for a program like this, would be full-time, and they work on engaging their local community, come together as a community of practice of with the other AHSN managers. There is a coordinating team, lead team, in this case it is North East North Cumbria for the program, and then a responsible chief officer from one of the AHSNs, which in this case is myself. And then we have a set of agreed ambitions, metrics we work to with our commissioners, NHS England. And having reliable data is clearly key in that, and I'll come back to that. So we then very broadly describe this program as improving the identification of people with cholesterol, which in practical terms means seeking to know the cholesterol of everybody in the age group 40 to 75. Health checks are somewhat controversial in primary care. And I think because the way it operates is bringing people up for a set interaction with a healthcare professional, often a nurse, to go through a series of healthcare checks. Many believe it doesn't help issues like inequity. The people who tend to go for these checks are like the people in this audience. And certainly the view of many of us is we need to move to a more opportunistic approach to identifying, knowing people's cholesterol, rather than insisting they go on a health check. And the anecdote I share is, this is a pre-pandemic interaction where I not had my cholesterol checked since I was 30, when I had it checked as part of a healthy volunteer study I participated in, and it was very low at that point. But I had to rarely go and see my GP, and I said, "Oh, whilst I'm here, can you do my lipid profile?" And the response was, "No, you have to go and have a health check." So of course, pandemics came, and I still don't know what my recent cholesterol is. And I think, particularly in the context of the reduced face-to-face interactions, a more opportunistic approach to taking opportunity to identify people's cholesterol is important. The second area is the database searches, which David has described, and these are really key, not just in identifying people who may have FH, but in identifying people who have not on a statin, or have not been offered a statin, or are not on a high-intensity statin, in people at either high CVD-Q risk or with established CVD disease. David has spoken about the FH case finding, and then we go into the primary prevention, secondary prevention arms. Primary prevention is essentially all around persuading people, giving them information about the benefits of statins. Secondary prevention, again, but with also escalating to the newer therapies that are available and making higher use of ezetimibe. A key element in any national program we run is having reliable data. So in the case of atrial fibrillation, the QOF data were what we used, which were pretty comprehensive. Some primary care practices can opt out of QOF, but few did for atrial fibrillation. So we had a good base measure of the number of people identified and the number of people anticoagulated with the CHAS2 VAS2 score. The other thing we had was good data on the anticipated expected prevalence of atrial fibrillation from work by Public Health England. For this program, we haven't had good QOF data on cholesterol management. So we are going to be very reliant on the implementation of CVD Prevent, being led by Matt Kearney, which is now proceeding. There's some uncertainty about when it would be implemented, but over 3/4 of primary care practices have signed up to this, and this should be producing reports by early 2021. This automatically extracts patient-level data out to produce an anonymized report of people with high-risk conditions, people with pre-existing CVD, and then can flag possibility of an undiagnosed high-risk condition. And this will be a very powerful tool because it will, unlike QOF data, will be a readout every 3 months is our understanding, and that's quite valuable in terms of feeding back to practice and identify areas to focus on. So this then tells you where your areas of opportunity are and where you might focus on to get the most gain as a CCG or as a primary care network or individual practice. And that will generate reports at PCN level and higher, and across the AFBP cholesterol management domains. So these are the current metrics we are planning for the joint program. Metrics are always a challenge. You have to try and make sure they're used as servants and that they don't become masters, but the history of metrics is they often start to run your program and you can get undesirable and anticipated actions in response to metrics. So we will be looking at how many cases of FH we find. We will look at a measure of engagement of the system through CCGs. With the lipid management program, we have a 4 or 5 step measure of how engaged our communities are with programs we run. We're looking at high intensity, percentage of statins that are high intensity that are prescribed, because that measure is already there. We're going to look at the percentage of ezetimibe that's prescribed. And then these last 3 are all prescribed, are laid down by the AAC team. So these have been there already. You'll notice there is arguably one key one there. There are many metrics we could put in, but we do need to look, and we will be able to, when we have CVD, at adding in a metric for the percentage of people with high cardiovascular risk or established cardiovascular disease who are on statin therapy, which would fit between metrics 2 and 3 on this slide. David has talked through this, so I won't repeat that. This is a little bit more detail on the North East North Cumbria experience, which Dermot led. So I shouldn't really be talking to this slide because he would do it far more justice than me, but shows the way they ran it, a very well organized approach to selecting patients for screening for FH. And note, it is not just a cholesterol in primary care. They then go to a nurse-led clinic where there are 113 invited to that to check on the DCINS criteria, and 62 samples end up with identifying 24 new patients. And then with the cascade testing, as you can see on the right side of the slide, 78 first-degree relatives and 166 second-degree relatives. Very well run, and this is the approach we would like to emulate in the AHSN network national program. And indeed, this is the way we like to run any national program, to have an exemplar which has worked not just in one CCG or one hospital, but has worked across a system, and then you can be confident about rolling it out. So I think this now is a joint program, and I think that's important. It was they've set up at different times. We were due to launch in April, but we suspended the launch of national programs because the AHSNs were focusing on the response to the pandemic. The AAC program was running already with the PCSK9 inhibitors, so we've had to weave all this together with a little bit of retrofitting. But we now have one national programme with 2 separate work streams, but the coordination is by my AHSN colleagues, many of whom I worked with in the past before I moved to Oxford, and I was based in Newcastle up in the northeast. I won't go through this. Is the kind of governance arrangements are slightly complex, but we do report through different routes, but ultimately this all goes to our commissioners, NHS England or the Department of Health. And the other thing I would mention is other work we've done is my team, working in collaboration with GIRFT and the Primary Care Cardiovascular Society, is building on some pragmatic guidance on service organisation we developed for stroke services at the beginning of the pandemic. We recently published some pragmatic guidance with a primary care group on approaching CVD prevention, and we're currently looking to produce system-level guidance for integrated care systems in the end of this month. And the only final comment is, I think this is absolutely the time for us to work on lipid management, because we have the support of the ambition of the long-term plan for FH diagnosis. We have the establishment of the genomic medicine services and the genomic laboratories. And for me, this offers a fantastic opportunity to show the deployment of genomic medicine in primary care at scale, having a real impact on patient outcomes.